Hello, my name is Stephanie Maya Lopez. I'm a forensic psychiatrist with the Oregon Health and Science University. I'd like to welcome you to my talk about mental illness and functional capacity and your role as a court visitor. Before I get started, I'd like to provide a few cautions about this talk and what its limitations are. The information in this presentation is not exhaustive, and every individual situation needs to be assessed for its unique fact pattern because each situation is unique. The diagnostic information contained here is not complete and cannot be used to make diagnoses. Instead, I have provided a framework for you to learn more about mental illnesses and how it might affect an individual's level of functioning in the community. I mostly use DSM-5 terminology, but there is older terminology in common use, and you will encounter that. I encourage you to look things up if you encounter a diagnosis that you have not heard of before, and figure out how it maps onto the new DSM-5, which I'll talk about in a minute. And the final caution is that I am a psychiatrist. I'm not an expert in the law. So really my talk is focused on how people are affected by mental illness and whether or not it affects their functioning in their daily life and whether they can make safe and sound decisions. The first thing I want to talk about is what is the idea of mental illness in the first place? Mental illness is often thought of as a behavioral disorder because that's when we notice the mental illness the most. Somebody is doing something that is outside the norm and that may be problematic for that individual or the individuals around them. However, mental illness is also a neurobiological illness that is caused by genes, environment, and other kinds of physiological dysfunction in the brain. And it's important to remember that because simply by changing a person's behavior, we may not be changing the underlying mental illness. Mental disorders also have a lot of physical causes and effects. For example, schizophrenia is a developmental disorder. It actually begins often in early childhood or even thought to begin in utero while a child is in the womb. But the symptoms do not present themselves and become apparent until the late adolescence or early adulthood. It's associated with lower brain volume, and we do know that neurotransmitters in the brain's levels and function are different than people without schizophrenia. The other important thing to remember is that mental disorders have a lot of physiological and biological effects far beyond the brain. People with schizophrenia, for instance, have higher rates of neurocognitive disorder, which is also known as dementia. And schizophrenia also is associated with a higher risk of cardiovascular disease, such as stroke and heart attacks. Mental illness is really common. 50% of all people in the United States will develop a mental illness during their lifetime. Many people live independent lives, work, marry, and raise families, and you might not know that a person has mental illness at all during their lives. In other words, there's a really wide range of functioning seen in mental illness. For example, Kay Jamison Redfield is a woman who is a full professor at a prestigious university who is a noted researcher in the field of mental health. She herself suffers from significant mental health diagnosis, and yet she is extremely high functioning. And again, you would probably not know she ever had such a mental illness if she did not tell you. In other words, it is not the diagnosis of a mental illness itself that is disabling to an individual. It is how the illness affects the individual and what treatment and supports are in place that determine the level of functioning, not the mental illness itself. I want to introduce you to the DSM-5 if you're not already familiar with it. This book is commonly called the Bible of Psychiatry. It is a comprehensive book that encompasses all of the known and identified mental illness diagnoses, and it has the criteria for the diagnosis for each mental illness that we've identified. It also has valuable information about what the mental illness looks like when it manifests in an individual. And I would recommend that if you do not have a copy of this book, try to gain access to it because it may become really useful in your work. It's published by the American Psychiatric Association, and this is the DSM-5. It's the latest iteration of the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders. And you should always be careful to use the most current edition. This edition just came out recently, so I don't anticipate there will be a new edition soon. There were some significant changes in the DSM-5 from the DSM-4 text revised edition that you may have encountered in your work already. The DSM-4 and previous used what's called the multi-axial system, and you may have seen that with Roman numerals 1 through 5 and different diagnoses and comments in each section. That has been eliminated, and now diagnoses are just listed like other illnesses. They also eliminated the Global Assessment of Functioning, the GAF, and the diagnosis of mental retardation has been significantly changed, and the name of that diagnosis has also been changed to intellectual disability, and I'll tell you more about that in a few minutes. Other changes in the DSM-5 are unlikely to have a substantive impact on the evaluation of guardianship, but I do recommend that you refer to the DSM-5 when you have questions. Before we talk about mental illness, I want to talk a little bit about the mental health professionals that you may come in contact with, either in reading their records or interviewing during one of your investigations and your reports as a court visitor. A psychiatrist is a physician who went to medical school, who then went on to specialize in the evaluation and treatment of mental illness. A psychologist is an individual who received a doctorate degree in psychology. Often psychologists have special expertise in testing and can provide very comprehensive evaluations that may be useful to you. Psychiatric mental health nurse practitioner is a licensed independent practitioner at the nursing level who also is qualified to evaluate and diagnose mental illness. There are also various types of social workers and social work associated professions, such as QMHPs and QMHAs. You may find a rich trove of information in their documentation because they often work very closely with individuals with mental illness and may be able to provide a lot more information about a level of functioning than, for instance, a psychiatrist who often has less contact with the individual. Then there is also registered nurses and licensed practical nurses who may have contact with the individual and have valuable information. For most of the rest of this talk, I want to spend time talking about some of the most common mental disorders and how they may or may not affect functioning in daily life. We'll go through almost all of these. We'll talk about intellectual disability, primary psychotic disorders such as schizophrenia and schizoaffective disorder. We'll talk about mood disorders such as depression and bipolar disorder. We'll touch briefly on anxiety disorders and briefly again on alcohol and substance-related disorders, personality disorders, and eating disorders. A presentation on medical delirium will be in the next session of this lecture. I will also mention HIV, as that is a common source of decreased level of functioning when a person has HIV. Intellectual disability. This diagnosis is now called intellectual disability. It used to be called mental retardation, but it was changed in this iteration of the DSM for various reasons that I won't discuss here. But do know that those terms are now they're interchangeable in a functional way, but the more modern nomenclature is intellectual disability. Intellectual disability is marked by deficits in reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience. In other words, intellectual disability often impacts a wide variety of functioning in many settings, including work, home, school, and social settings. By definition, it limits adaptive functioning and communication, social participation, and independent living to some degree or another. There are different domains to think about in the realm of intellectual disability. In general, it's thought of as having three main domains that may have impairment. There's the conceptual domain, also known as the academic domain, and that is the domain that most people are most familiar with because it is demonstrated by impairments in math, reading, language, other kinds of schoolwork abilities. However, there's also another impairment that it can be seen in intellectual disability, and that is judgment in novel situations. I want to take a minute to talk about that because that is where you may find rich information regarding whether a person is able to safely and independently live without a guardian or a decision maker. For example, intellectual disability often impairs a person's ability to apply what they have learned in one setting and transfer it to another setting. So a person who rides the same bus every day and the bus is painted the same way and it has the same route and the stop is the same place, they may be able to navigate that just fine. However, if the bus has been rerouted for some reason or they've changed the bus schedule, this person may not be able to navigate that novel situation and may get on the wrong bus or not know what to do. You can easily imagine that there might be situations like that in which there might be impairments in safety and reasoning when in unsafe situations. Another domain in intellectual disability is the social domain. For some people with intellectual disability, they may have decreased empathy and awareness of others' thoughts, feelings, and experiences, and they may have impairments in social judgment. Again, I would give the hypothetical example of someone who is riding the bus and a person gets on the bus and starts to establish a relationship that is somewhat exploitative. They may not have the social judgment to navigate that situation safely. And finally, there is the practical domain, which may be the most important domain with regards to guardianship. And that is the ability to participate in personal care, money management, and self-management of behavior. In other words, the ability to refrain from lashing out or the ability to refrain from sexually inappropriate behavior and things like that. Having said all that, intellectual disability has a very wide range of functioning. So wide that they actually got rid of the IQ standard for diagnosing intellectual disability because it was found that IQ is really a poor predictor of how well somebody could function. Nevertheless, I do still believe that IQ is a good rough indicator of where a person lands in the level of functioning. For example, an IQ in the range of 71 to 84, which used to be called borderline intellectual functioning in the old nomenclature, can be associated with a relatively high level of functioning or one much lower than expected. And even a lower IQ of 55 to 70 can vary and function widely. Nevertheless, an IQ less than 50 is highly unlikely to function safely and independently because the deficits are at that point so wide-ranging that there are many impairments. A few things to remember when you're evaluating an individual with intellectual disability. People with intellectual disability, just like the rest of us, want to look good. We want to be seen as functioning well in our society, in our role. And so when you're evaluating somebody with intellectual disability, you might need to understand that a person with intellectual disability really might want to present to others as higher functioning than he or she actually is. And this occurs actually at the upper levels of intellectual disability. In other words, the more mild forms of intellectual disability, because they know they have an intellectual disability, don't really want to have it, and don't want others to really realize that they have it. There also may be a need to please the examiner or other people and try to give, quote unquote, the right answer. And so it's important to keep that in mind as you're interviewing the individual. Another important consideration is that an individual with intellectual disability might actually appear to be higher functioning due to rote or practiced responses, because intellectual disability does not necessarily mean that a person cannot learn the appropriate response at a rote or memorized level. The key is to see whether that individual can think outside the box, can explain the situation in another way or explain what they're going to do in another way. And I'll talk more about that during the interview part of this talk. If you want to know more, the DSM-5 has an excellent summary of deficits and domains for each level of severity that may help to shape the questions that you ask as you do your report. Next, I want to talk about psychotic disorders. And psychotic disorders encompass a range of disorders that are all associated with what is known as psychosis. Psychosis is a specific term of art in psychiatry, and what it means is the presence of delusions, hallucinations, and disorganized thought processes. Delusions are fixed false beliefs that are often bizarre. It is not simply a belief that other people hold that may be unusual for that social group. It is much more on the order of believing that someone has been replaced by an alien, or that there are implants in someone's skin, or things that are clearly not believable in real life. Hallucinations are physical sensations that an individual may have through their 5 senses. One can have visual hallucinations in which they see something that is not there, or one can have auditory hallucinations in which they hear something that is not actually audible to other people. This is a physical phenomenon in which different parts of the brain actually misfire and create that sensation for that person. More rarely, you can have the sensation, a person can have the sensation of bugs crawling on their skin and other somatic hallucinations. In other words, hallucinations that affect the rest of their body. And finally, the third part of the definition for psychotic disorders is that a person's thought processes become very disorganized. A person with disorganized thought processes may string meaningless words together. They may make up words or meld 2 different words together and have it make a special meaning only known to them. They may be very tangential and start talking about one thing and slowly derail until they're talking about an entirely different situation. Or they may be so disorganized that they may only be able to say a few words. Psychosis is seen in the following disorders: schizophrenia, schizoaffective disorder, unspecified schizophreniform disorder, and delusional disorder primarily. There are a few other psychotic disorders, but those are the main ones you might encounter. The important thing to understand about psychotic disorders is that there are very common deficits in functioning when a psychotic disorder is active. And that may include self-harm for various reasons, deficits in self-care to the point where an individual is medically unsafe, severe health problems, and harm towards others. On average, a person with a psychotic disorder is no more likely to harm another person than anybody else. However, there are certain kinds of psychotic symptoms that can lead someone to be more at risk for harming someone else. Individuals with psychotic disorders do a number of things that may impede your evaluation. Sometimes an individual with psychotic disorder will try to mask their symptoms because they know that they are abnormal and they worry about loss of autonomy. They worry about being sent to the hospital and things like that. On the other hand, some people with psychotic disorders simply do not recognize that they have the illness. So they may talk freely about their delusions and their hallucinations, but they may not recognize that it is unusual, or they may feel very defensive that other people are saying that they have this psychotic disorder when they have a delusion that they believe to be the truth. And that may make it challenging to interview an individual like that. On the other hand, there are some delusions that can be very subtle, but have a pervasive illness on pervasive influence on decision making. I want to shift the focus now to mood disorders. Mood disorders mainly are comprised of major depressive disorder and bipolar disorder. Major depressive disorder is one of the most common mental illnesses in the United States and in the world. Over a course of 12 months in the United States, on average, 7% of people have an active major depressive disorder. There's a higher rate for ages 18 to 29, and more women than men suffer from major depressive disorder. Major depressive disorder in general is not associated with psychosis, like I talked about earlier, but it can be. So you may see a specifier in the records that says with or without psychotic features. 1 in 5 people with major depressive disorder have psychotic features. And so it's important to recognize that and explore that, because that may be a major impediment to safe decision making. People with major depressive disorder often have distressing hallucinations, such as the devil's voice saying that they will be tormented in hell, or command hallucinations to kill oneself or others. Often these kinds of hallucinations are what are known as ego dystonic. In other words, the ego, the person, is feeling very distressed by the hallucination. That is a very common feature. It's also common for an individual that has psychotic features to have delusions. For example, a mother may stop feeding her baby because she believes that God is taking care of it. People with major depressive disorder can appear to be very well functioning, but might not actually be functioning well at all. For example, the prize-winning author William Styron, on the eve of winning a famous international literary prize, was almost unable to get himself out of bed to go receive the award. He was able to mask his symptoms, he presented well, he covered his deficits, but he was profoundly impacted by major depressive disorder and wrote about it in a book called Darkness Visible if you're interested in reading more about it. Suicide and suicide attempts are common in major depressive disorder. The key feature to remember here is that many people who attempt suicide or successfully commit suicide deny suicidality to other people. So we must rely on other cues and hints that lead us to believe that a person is at risk for suicide. Another important feature to remember is that there is cognitive impairment with poor memory, concentration, and ability to plan and execute tasks in major depressive disorder. In other words, a person with major depressive disorder at a severe level may be unable to manage finances and make other safe decisions. There's also the phenomenon of double depression. Double depression is when an individual has a chronic low mood, and that can be due to a personality disorder, dysthymic disorder, or life stressors. But then it's coupled with an acute exacerbation of major depressive disorder. This is important to remember because it's associated with lower functioning and a higher suicide rate. So if you see somebody with a personality disorder and major depressive disorder, or dysthymic disorder and major depressive disorder, the index of suspicion that a person might not be functioning as well as he or she thinks he is goes up. Most often, what's seen in terms of ability to function is an inability to attend to basic self-needs. That can be something like not bathing, but it can also be something like not being able to eat or not being able to take care of basic medical problems such as diabetes or high blood pressure or other illnesses. There's a very severe form of depression called catatonia, which is also seen in schizophrenia when it becomes very severe. And catatonia is a complex neurological complication of these two mental illnesses. It can result in a person who is in, quote unquote, a stupor. In other words, a person who may not be communicative, they have an inability to move normally, they may grimace with their face, they may be able to only say a few words at most, or they may be really agitated and randomly strike out at people. It's important to remember this syndrome because if you see somebody diagnosed with catatonia, it can be fatal. It is associated with a risk of sudden death that is still as yet unexplained by science. Another important mood disorder to recognize is bipolar disorder. So major depressive disorder is often referred to as a unipolar disorder because mostly the mood is a low. In bipolar disorder, we have lows, like depression, and highs, and that means a mania, true mania. This is not to be confused with a mood swing that may happen within the course of a day or hours. These are distinct periods of 3 or more days where a person has increased energy level, decreased need for sleep, often have either elevated mood or their mood becomes so elevated it's uncomfortable and they become very irritable. And they may have inflated esteem or grandiosity. In its more extreme forms, a person with bipolar disorder may believe that they have special powers and abilities. It can be associated with an increased sexual libido and hypersexual behaviors towards others, and it is often associated with impulsive and reckless behavior. Bipolar disorder may also result in an individual spending large amounts of time working on tasks but unable to plan them well or complete them. Often in the course of these tasks, a lot of money is spent. I know of an individual in a rural Midwest state who had very little money. He lived on a subsistence farm income, and when he became manic, he bought airplanes, and his farm was filled with airplanes. So you might see a pattern of very unusual purchases that don't coincide with what the individual would normally spend money on. Possible effects on safety and ability to care for oneself in bipolar disorder can vary widely. They might not believe that they need treatment for a medical illness because they have special powers, or that they have a special religious connection, or they may believe that they don't have the illness at all. Another effect, a possible effect, would be not wearing clothing adequate for extreme weather. And I can offer the example of an individual who was discharged into an icy Midwest winter snow, an ice storm, and he refused our offer of a coat because he believed that he was Jesus and he would not ever die. There is an increased risk for suicide at just about the same rate as major depressive disorder. You may also encounter individuals with bipolar disorder who are aggressive towards others, and that often has to do with the agitation associated with the manic episode. Hypersexual behaviors in bipolar disorder may lead to public masturbation or inappropriate sexual contact with other people, and also engagement in unsafe sex practices. And finally, there may be reckless spending due to gambling or bizarre excessive purchases. With regards to general anxiety disorder, I only have to say this, which is generalized anxiety disorder is associated with worries about everything and anything, and it is really less likely to cause the kinds of functional impairments one might see that lead to guardianship. Post-traumatic stress disorder, a very common mental illness. On the other hand, it would have to be very severe to lead to the level of impairment leading to guardianship. You might see in such a case a person who dissociates. In other words, the trauma has been so severe that under times of stress, an individual almost goes out of themselves mentally and is not present in the same way that you or I are present in a situation, and at that point may not be able to act appropriately. Having said that, PTSD is commonly associated with having also another major mental illness, such as major depressive disorder. Alcohol and other drug-related disorders. Alcohol and other drug-related disorders don't, in and of themselves, result in the kinds of functional impairment and permanent disabilities one would see that leads to guardianship. But chronic substance use and chronic heavy substance use and alcohol use can lead to long-lasting effects on the body that are permanent, and that includes effects on the brain and ability to function. One important example is a syndrome called Wernicke-Korsakoff syndrome, and that is caused by the brain damage associated with chronic heavy alcohol use. And what you might see in that situation is a person who is amnestic, does not remember periods of time, and this is not the same as an alcoholic blackout. So when somebody drinks alcohol and then they wake up the next morning and they don't remember the night before, that's an alcoholic blackout because they were intoxicated at the time that they were trying to lay down these new memories and were unable to do so. That's different. This amnesia comes even when a person is not using any alcohol because the parts of the brain that lay down new memories are damaged. Another important feature you might see in Wernicke-Korsakoff syndrome that's relevant to guardianship is confabulation and storytelling. Just as there is an inability sometimes to lay down new memories, there can also be an inability to retrieve old memories, and you'll see that with confabulation and storytelling in Wernicke-Korsakoff syndrome. In other words, there'll be incorrect memories that the person holds to be true and may even act on that arise spontaneously. For example, a person may remember that he bought a VW bus and drove it across the country in the early 70s, but may also falsely remember that the bus was in an accident and the only way it could be repaired was by cutting the bus in half and soldering the whole bus together again into one piece. This is probably produced by an impairment in how the person retrieves the memory, and they can't really remember the spatial and contextual information that was related to the event, so they basically, an individual, fill in the gaps. That happens for many people. That's actually a very common thing, but in Wernicke-Korsakoff it is clearly much more pervasive. There also may be poor coordination and problems with walking, which may lead to falls. And that is relatively common in lots of problems with chronic alcohol and substance use. Another common result of chronic alcohol use and chronic methamphetamine use is neurocognitive disorder, which was previously called dementia in the older nomenclature. A person may have inability to navigate new situations. Again, there may be memory problems and problems in attention and being able to concentrate. Alcoholic hallucinations are also relatively common in people who have used a lot of alcohol over the years. They may hear mumbling or sounds or voices that are chronic. That usually does not in and of itself cause an impairment, but it's an important feature to recognize. Various substance use disorders, such as alcohol use disorder, amphetamine use disorder, opioid use disorder, are also associated with other major mental illnesses that also may be impacting the person's ability to function. I want to take a few minutes to talk about personality disorders. Often it's said that personality disorders are not mental illnesses. However, they do qualify as mental illnesses in the DSM-5, and they do often require psychiatric treatment. However, they are a different class of disorders because personality disorders are often associated with the ability to change one's behavior if necessary. In other words, there may be impairments, but the impairments may be due to the person's unwillingness to change their behaviors rather than an inability to change behaviors. You may see diagnoses such as antisocial personality disorder and borderline personality disorder. These are the two most common personality disorders. The thing to remember about personality disorders is that these two personality disorders in particular are associated with other major mental illnesses that can lead to severe impairment. Exceptions to this could be schizoid personality disorder and schizotypal personality disorder, and I would leave you to read up on that. These are very rare personality disorders, but they should alert you to inability to function. Somatic symptom and related disorders. These are formerly known as the somatization disorders. The most common one is somatic symptom disorder. It's a rare disorder, but you still may see it in a guardianship evaluation context. It's characterized by extreme preoccupation with physical symptoms, often with little or no medical evidence of an illness. Why this may lead to an impairment is that it can lead to tests, surgeries, and medications, as well as other interventions that are in and of themselves unsafe. An individual with severe somatic symptom disorder might have dozens of needless surgeries, dozens of needless procedures, all of which carry medical risks. And studies do show that the mortality rate for people with somatic symptom disorder is higher than the general public. It's also important to remember that this illness in particular is not in conscious control of the individual, although it may seem like it is. A person may say, I have this list of physical illnesses, I'm not getting the help I need. They'll list off their symptoms, they will sound very knowledgeable about it, but simply cannot really understand that the best medical knowledge we have today has ruled out those illnesses. It's also important to remember that people with somatic symptom disorder also often have significant medical illnesses that have been confirmed. Eating disorders. Eating disorders are a relatively common group of mental illnesses. Most notably, there's anorexia nervosa, which is characterized by caloric restriction, intense fear of fatness, and despite being very thin. And this is important because this can represent a safety issue if certain medical thresholds are met. An individual with an eating disorder such as anorexia nervosa might use laxatives or excessively exercise or use enemas or self-induced vomiting. And all of these things are associated with significant risks. And I'll talk more about the self-induced vomiting in a moment. How do we measure what medical safety is for an eating disorder? In anorexia, we often think of somebody being low weight. The true measure of someone's medical safety is what is known as body mass index and a few laboratory results. Body mass index is a measure of your weight as it's associated with your height, and it's a ratio. So a body mass index of 17 or less is entering the danger zone with regards to physical safety, including sudden death. Because when a person does not eat enough calories, they can have electrolyte imbalances and have abnormal sodium, magnesium, and potassium levels in their blood. This may cause sudden cardiac arrest or seizures. Also associated with a body mass index of 17 or less is cognitive impairment. So the largest consumer of glucose in your body is your brain. And if your brain is not getting enough glucose, it can't run properly. And there's lots of scientific literature that shows that there's cognitive impairment when a person becomes unusually thin. Bulimia nervosa. Bulimia nervosa is characterized by binge eating, sometimes with self-induced vomiting as well. Self-induced vomiting is associated with seizures and sudden death. When an individual vomits too many times during a day or vomits over the course of a chronic, longer period of time, it can cause electrolyte imbalances, which again can lead to sudden cardiac arrest or seizures. In the case of eating disorders, I strongly recommend that you consult with a medical provider, either a primary care doctor or a psychiatrist, to ask about whether this person is in the safe weight range and whether their blood electrolyte levels are within the safe range. And finally, HIV. HIV is not particularly common in Oregon, but you may see HIV individuals. HIV is associated with neurocognitive disorder, also known as dementia, and also psychosis, which is surprisingly common. Usually hallucinations, delusions are more rare. The hallucinations usually do not interfere with a person's functioning. The delusions may or may not, so it would be important to assess for that. I want to take a minute to talk about medications and mental illness, because this may affect how you deem the person's safety in situations. With the notable exceptions of intellectual disability and personality disorder, most of the illnesses I have described here require treatment with medications if substantial improvement is to occur. So if a person is refusing medications or unable to take them regularly, that increases their risk that their functioning will go down and at some point become unsafe. Treatment with psychiatric medication often prolongs life. An important issue to recognize is the phenomenon of anosognosia. I touched on it earlier when I talked about psychotic disorders and when a person cannot recognize that they have a mental illness. That is the longer way of explaining what anosognosia is. A person with mental illness that does not recognize that they have it is not a person who is simply in psychological denial. There are physiologic mechanisms in the brain that are not working properly that allow the person to encode and understand that they have the mental illness. And so, again, this is not something that is within the purview of their own control. It is a neurobiological phenomenon. When you're looking at medical and psychological records, please do look for some of these items because they may show you a lot about the abilities to function. There's the Vineland scale, the Allen cognitive level screening, IQ and IQ tests. That will be a source of rich information for you. In the narrative portions of medical and psychological records, it's very important to look at signs of how the individual is functioning. Again, the diagnosis itself does not determine whether a person meets any kind of legal criteria for guardianship or whether they are safe or unsafe. You want to look at clues in the records, like how did the person get to the clinic? Did they ride the bus or did they require somebody to drive them there? Are they able to cook safely in their home? Did they have a fire in their kitchen? Are they paying their bills? Do they have a payee? Things like that. The other thing you want to look at in the medical and psychological records is evidence that a person might be spending restlessly, being exploited financially, is engaging in unsafe sexual behaviors, and those records right there might be more found in primary care records than psychiatric records. And in the psychiatric records, you're more likely to find information about whether the person is acting aggressively or failing to maintain physical health to a minimal standard. Interview tips. Interviewing a person in this situation is a challenge. Oftentimes, individuals who are being interviewed do not want to be interviewed. By nature, these are contested cases. And you may find that the individual is unwilling to speak with you much, if at all. There are a couple of things you can do to prepare yourself to have the best interview possible. Prepare for the interview by reviewing records in advance, because that information that you have access to may help guide you in how you're going to ask questions and what kinds of issues you're going to focus on in the interview. Once you establish rapport with the individual, insofar as possible, keep asking questions because you want to drill down to the why of this person is behaving in such a way that it causes someone to petition for guardianship. Their first superficial answer is probably not the real answer. And so it's important to keep exploring the issue of why somebody did something. Sometimes an individual actually has a perfectly rational, reasonable reason for doing what they did, but on the surface it may look like a bizarre or unsafe decision. And conversely, a person may be able to give, quote unquote, the correct answer with regards to why they may have done something when really there's much more underneath, such as a delusion or a significant cognitive impairment. Don't rely on rote or practiced responses. As I talked about in the section with intellectual disability, a lot of us, whether we have mental illness or not, we learn how to give the correct answer, whether we truly understand it or not. And so I recommend that when you get an answer, ask them more. Ask them to explain it, or ask them to phrase it another way, and see how they do. Patience during these interviews pay off. The amount of time you spend with an individual really is an indicator of them being able to loosen up, relax, get to know you, and they may reveal more to you. On the same note, it's important to not interrupt the individual, because often they might be able to give you answers that seem very reasonable, but if you just let this person talk and talk about what's on their mind, it may lead you to other areas to explore with regards to safety and ability to make decisions. Thank you very much. This is all I have for my portion of this presentation. If you have any questions, I encourage you to email me. My contact information is on this slide.